Hi there. I'm Dr. Michael Trayford, board-certified chiropractic neurologist and founder of Apex Brain Centers in Asheville, North Carolina. I'm very excited to be part of this virtual neurology summit alongside these great presenters, educators, academics, clinicians, talking about everything to do with pain and the brain. My part in this summit is going to be the connection between concussion, pain, and addiction. My role for the past 20 years has been as a clinician with clinical outcomes type of research done within our center. The first 5 of those 20 years was spent primarily in pain management and physical medicine and rehabilitation. That transitioned into movement and balance disorders because of heavy emphasis on vestibular function, eye movement therapies, etc. And from that time, for the past 10 or 12 years, I've really been focused on adulthood learning and behavioral issues, primarily in the areas of concussion and post-traumatic brain injury, as well as addiction and substance use disorders. So that's what I'm trying to do today as best I can, is bring that together and understand the connections and correlations between these oftentimes devastating conditions that people are dealing with and trying to get through their life with. So without further ado, I'm going to go right ahead into the presentation. And the presentation, once again, is entitled The Concussion Pain Addiction Connection. Now, any one of these topics, as we well know, concussion, pain, or addiction, can go through its entire course of study, master's and doctorate levels for just one condition. The fact is, there's a lot of folks in these arenas, traumatic brain injury, pain, addiction, understanding there's things going on the other side of the fence that they need to be looking at. And this has been happening for the past 20, 30 years or so, where you have folks that are really connecting the dots between these things. So that's what I'm going to try to do in the next 25 minutes or so, is connect the dots, talk about some basic neurophysiology, talk about connections between these 3 things, talk about a case study, and some interventions that we did with one particular case study that we'll be talking about. So here we go. You have folks like John Cargan, a PhD from Ohio State University, that's been looking at these things, particularly all 3 that I spoke of, the connections between them, for over the past 20, 25 years or so. And he says substance abuse is a risk factor for having traumatic brain injury. Now, stopping right there, we all know this. We know if somebody has a problem with alcohol and they go out and have a few drinks, get in a car, and wind up having an accident and hitting a tree and creating a brain injury, that's direct cause and effect. They drank, they had a brain injury. So there's incredible correlations that are very well documented and understood and reliable there. The other side of the coin is traumatic brain injury being a risk factor for developing substance use problems. This is much more difficult to measure, to manage, because there's so many factors involved from a demographic standpoint, the type of brain injury, the demographic makeup of the individual, age, gender, even looking at socioeconomic status, vocation. So many things are involved with trying to correlate these that it's a much more difficult thing to do. So what we're going to try to do is put together some of what's out there, make sense of it, but I think intuitively we all know, or at least by the end of this talk, we'll have a greater understanding that TBI can in fact lead to substance use and other addictions. So circling back, it's well established that alcohol and substance use leads to traumatic brain injury. We know this. So I'm just going to expand on this a little bit and talk about what I call, I don't mean to make light of things, but the fact is that most of these things happen as accidents. So I have what I call the hold my beer and watch this phenomenon. There's a lot of things that particularly young males, 18 to 40 or so, that they do that is not well thought out and often involves alcohol or different substances that lead to brain injury. I had just as a quick aside, a patient who basically did a poorly thought out stunt, as I have mentioned here. He was driving down the Las Vegas Strip after a 5-day cocaine bender and thought it would be appropriate to jump out the window of a car, or thought he could actually do this without getting hurt at about 45 miles an hour. Well, needless to say, it led to a significant concussion and thankfully not a lot worse. But poorly thought out stunts, doing things under the influence, can very often lead to brain injury. Fights. There's probably not a bar fight that's happened that didn't involve alcohol to a certain degree and or other substances. This also includes domestic abuse. Many times people are codependent and they're doing different types of substances or drinking, whatever it is they do, and they get into fights and people wind up getting their brains injured. False. What happens is when we dampen functions of our cerebellum, of our vestibular system, of our eye movements, we start to develop a lesser ability to maintain balance in a gravitational field, which leads to falls, which leads to brain injuries. So not only do we need to strengthen these systems, we also need to pull away the things that are dampening these systems. Car accidents we spoke about. There's estimates as many as 60% of those with traumatic brain injury have a prior history of substance use disorder, which is interesting because when somebody injures their brain, they actually develop a greater tendency to either come out of recovery or use substances at a higher level than they were previously using. So this is significant to note if you're seeing these things in your practice. So the other side of the coin, does traumatic brain injury and concussion lead to alcohol use disorder, substance use disorder, or other addictions? My supposition, my experience, my opinion is that yes, they in fact do. Most clinicians I speak with can draw these correlations as well and understand that yes, they do in fact lead to addictive behaviors. And we'll talk about why. Several studies suggest that 10 to 20% of those that have had their brain injured will develop a first-time substance use disorder, usually to do with the medications they're taking after the brain injury that lead to other things. Estimates as high as 50% of those in active treatment for substance use disorders have a prior history of traumatic brain injury. I get calls all the time from people out of addiction treatment programs saying that they want me to evaluate someone who's been there because they have a prior history of traumatic brain injury. Now, the mental health providers do a phenomenal job working with individuals that have addiction to all types of behaviors and substances, but they're not as well versed in the traumatic brain injury realm, particularly from a treatment standpoint. So this is why folks in the functional neurology, as well as the rehabilitation and mental health areas, need to work together. Cognitive capacities are impacted in traumatic brain injury. We know this. So we need to understand that being able to address these things will help decrease the implications with regard to substance use in the future. Also, too, the cognitive capacities affected in traumatic brain injury are very similar to those affected in substance use disorders. So the common issue is pain, right? So traumatic brain injury and addiction. There is a conduit, and something I talked about, the concussion, pain, addiction connection. There's pain right there in the middle. So we have physical pain, headaches, the most common side effect of or effect of a traumatic brain injury or concussion. People can also develop things like ringing in the ears, which can be perceived as pain. Also autonomic responses later in time, or aberrant autonomic responses later in time, like reflex sympathetic dystrophy. So physical pain leads generally to pain relief type medications, which often are opiates, which can lead to abuse. Psychological pain. People are dealing with fear, worry, grief, anxiety, depression, all of these things that are typically given medications to counteract or lessen the effects of. And we know with psychological pain, which is a huge part of traumatic brain injury recovery, things like antipsychotics, Seroquel and Abilify, as well as anti-anxiety agents like benzodiazepines, and some depression meds and other medications not only can be habit forming themselves, but can lead to formation of habits with other medications and behaviors. It goes without saying, the after effects of traumatic brain injury and concussion can lead to chronic stress, sleep disorders, and disability, all which can increase the risk of using drugs. So this right here is a paper, a large cohort of active duty military servicemen and women showed that the risk of addiction-related disorders increased after traumatic brain injury. So basically what happened was they looked at the electronic data of these people, and it was over 500,000 people, and they found those with mild traumatic brain injury and those with addiction, and what were the commonalities. And what they found was that airmen with mild traumatic brain injury were at higher risk for certain addiction-related disorders. And that hazards for alcohol dependence and tobacco or nicotine dependence, as well as certain non-dependent abuse of drugs, binge drinking, and things like that, were significantly elevated. But they noticed, too, there was a significant or consistent decrease over time. So as the individual's brains began to heal, they had less of a dependence or need to use the substances that were helping them along the way. So this is pretty interesting and gives hope and credence and clout to approaches that we can offer people that will help improve higher human functions, that can help battle the after effects of traumatic brain injury, pain, and addiction over time. So we've alluded to this. What is the common denominator that links concussion to addiction? Again, it's right in the title of this presentation, and that is pain. In some cases, more specifically, suffering. Physical and psychological pain and suffering is what leads people to find ways to comfort themselves. In a sense, we've heard that our brain, one of the big purposes of our brain is to avoid pain and seek pleasure. That's where this comes in. And this is why so many people use drugs when dealing with pain and the after effects of traumatic brain injury, to reduce their experience of suffering physically and psychologically. If you're interested in this arena, there's a great deal of information out there, and this is a pivotal paper, perspective paper in the journal Neuron in January of 2016 that really brought together a bunch of the information that was out there and started to say, what are the commonalities or common brain mechanisms of chronic pain and addiction? The authors, Ellman and Borsuk, they really did a phenomenal job at looking at pain and addictive disorders being characterized by common interests like impaired hedonic capacity or inability to feel pleasure, compulsive drug seeking, high levels of stress, impaired inhibitory control, incentive sensitization, things that we'll talk about, aberrant learning. These are all involved with chronic pain and addiction and things that we can address in our practices on a daily basis. So pain and addiction, what are the similarities? Some of what we just talked about, but I just want to lay out the similarities between pain and addiction so that we have a better understanding of how well these are connected. Number one, first and foremost, chronic pain and addiction are considered brain diseases. Chronic pain and addiction cause physical changes in the structure of our brains. So we have brain changes, brainstem changes, cerebellar changes, and sometimes peripheral neurological changes. But we have seen in both pain and addiction changes in the gray matter in certain parts of our cortex. So that is why it's labeled a brain disease. It's not necessarily a disease process causing the brain degeneration, but it's the trauma, it's the chronic exposure to substances, it's the behaviors that change all the time over time that cause these decreases in volume in certain areas. But the fact is they are linked that way. Pain and addiction also show lack of pleasure, typically with normally pleasurable types of stimulation. Sometimes complete lack of pleasure people experience, called anhedonia. Also increased reward seeking through something called reward deficiency. So what happens is the brain simply can't produce the rush or burst of dopamine that it was used to by typically pleasurable activities. So now we have a reward deficiency that requires acquisition of a stimulus like a drug that will increase those responses so that we can get the type of satisfaction that we need, neurologically speaking. Defense and avoidant behavior, very common between the two. Increased stress and sympathetic responses goes without saying. People that are in pain and people that have addictions are highly stressed individuals for the most part. Unpleasant sensory and emotional experiences. Augmented dopaminergic responses. This goes with reward deficiency. So sometimes they're too much and sometimes they're too little. But basically over time, dopamine responses, dopaminergic projections change dramatically, and we either need different substances, different behaviors, more of a substance, more of a behavior to get the same type of response that we had because of this reward deficiency that we experience. Aberrant neurological learning, that goes without saying. We have pain that becomes hardwired in the brain. Central mechanisms of pain are fairly well understood in that it's just not a problem with the head or the hand or the foot anymore, that this is actually a problem in the brain. Same thing with addiction. The brain learns very differently when it's under the influence, but also after chronic abuse and use. Sensitization, things that become unconscious now. We lose the ability of our front brain, our more human brain, our higher cognitive abilities to control impulses and desires. So certain parts of the nervous system subcortically become sensitized so that the simplest stimuli can trigger our need to seek reinforcement when it comes to pain, or attention when it comes to pain. It will reinforce the need to seek substances when we see a certain thing or experience a certain experience. So these are essentially become encoded in the brain and are under complete autonomous control with no influence from the frontal brain at that point. Drug seeking goes without saying. Pain and addiction are associated with drug seeking to relieve pain and suffering. So corresponding brain regions. We're going to kind of fly through this right here, just given the short time we have together. But pain and addiction have corresponding brain regions affected, as we can see by some of the things that we just talked about. So ventral tegmental area. This is the dopamine powerhouse. This is mesolimbic and mesocortical projections. Dopamine goes pretty much everywhere in the brain from the ventral tegmental area. So we have our mesolimbic projections from the ventral tegmental area to the nucleus accumbens and the ventral striatum. This is our reward circuit. The nucleus accumbens is our reward champion. This is probably the most widely studied area in all of addiction, but it's also implicated very highly in pain and reward reinforcement mechanisms in pain. Now we have the cortical areas: prefrontal, medial prefrontal, dorsolateral prefrontal, orbital frontal. These areas, when we have the ventral tegmental area project to these cortical areas, these are now the mesocortical pathways. These cortical structures, they champion impulse control, reasoning, planning, decision-making, our higher human abilities, the ones that we need to be able to make appropriate choices in life. We add in here to these mesocortical projections the anterior cingulate cortex. This deals with empathy, social interaction, emotional regulation, and decision-making, a key player as well in the addiction-pain connection. Insular cortex, very interesting area, dealing with moral intuition, empathy, emotional regulation, and get this, body representation. So the insular cortex is an area that we can access, like many of these areas, through standard applications that we have available to us. Physical therapies, postural therapies, vestibular and balance therapies, eye movement therapies, complex motor skills. These things all impact the insular cortex and other areas of the cortex based on improved body representation, which will help us from a cognitive standpoint, as we'll see. The amygdala for emotional responses involved in any type of pain and addiction. Hippocampus to do with memory, learning, emotional regulation, as well as spatial navigation. So just like body representation, our ability to navigate our environment spatially is directly related to higher cognitive abilities. So the more we can improve hippocampal function, the more we can improve frontal function, the more we can limit or decrease pleasure-seeking behavior that can be problematic for us. Reticular formation for behavioral arousal and pain modulation, and the hypothalamus, more specifically the HPA axis, for metabolic and autonomic regulation, which can become disturbed in any of these conditions. Really, the entire brain is involved, but these are the primary areas that we wanted to discuss here today. So laying things out a little bit differently, we have the ventral tegmental area that projects to the nucleus accumbens. This is our reward circuitry right here. Also to ventral tegmentum to prefrontal cortex and orbital frontal cortex for our mesocortical pathways. There's also involvement with the basal ganglia, of course, because there's dopamine involved. There's involvement with the limbic system to the amygdala. But right here, this is our motivational core. Nucleus accumbens, orbital frontal cortex, and amygdala. So emotional response, registration of reward values, and also just pleasure seeking. These three together are a very powerful entity, and we don't have control from the prefrontal cortex anymore. This motivational core can take over and get us into a lot of trouble. So a lot of what I'm talking about today is getting this prefrontal cortex back online so that we can have better control over everything that goes on underneath it. So in a simplistic view, this is a newer view in the area of addiction, in that we have the dorsolateral prefrontal cortex, which essentially will create the initiation or drive or want or desire to do something. So you think about something, you want to do it. And what that does is signals ventral tegmental area to excite dopaminergic projections to the nucleus accumbens, and that sets into play a cascade of events that will lead towards seeking or going after what it is that we want. This right here again is the mesolimbic pathway, ventral tegmental area to nucleus accumbens. And what happens is this dorsolateral prefrontal cortex and nucleus accumbens, in the beginning of addiction, in the beginning of pain, these two are very closely related. We have pain and we want to get attention for pain. So we have the nucleus accumbens jump in and kind of seek out that pleasure or soothing by getting attention or getting appropriate care for that pain. Same thing with addiction. We might think we want to do something, and then the nucleus accumbens steps into play. But then also, too, the dorsolateral prefrontal cortex should say, maybe we should do this or maybe we shouldn't do that. Decision-making, planning, all of these things are heavily involved together initially in seeking relief of some type of distress or pain. What happens chronically, the dorsolateral prefrontal cortex essentially peels away from the nucleus accumbens or grows away from it, so that now we have subcortical structures with the nucleus accumbens being one of the primary players calling all of the shots. Dorsolateral prefrontal cortex doesn't have much of an influence. This is the addict who now knows they shouldn't do something, but they simply have no control over using anymore, because this is a hardwired subcortical circuit at this point. So I want to go forward with a brief case study. And this is a fellow named Jeff. We have changed his name, but Jeff is a 25-year-old factory worker from Texas. This is a case that just left us about 2 weeks ago. And what happened was Jeff came in with multiple concussions due to football and rugby injuries. Reported about 8 to 10, but really wasn't sure. And this was his reporting. Basically, he hurt all the time, he feels stupid, he misses most everything, and he squirrels out. So we've got physical pain here, hurting all the time, and the rest is emotional and psychological distress. His chief complaints were just a regular day at the office for anybody seeing post-concussion syndrome: headache, memory decline, brain fog, dizziness, anxiety, panic attacks, obsessive thoughts, impulse control issues, on and on and on. And this guy was not a complainer. This guy really felt bad about saying all these things and really didn't want to get into the nuts and bolts of how bad he was feeling, because the more he thought about it, the worse he felt. So objectively, we saw with this individual gait and balance abnormalities. We can't get into the specifics right now, but fact is there was discoordination of movement, also shown by dysmetria, dysdiadochokinesia, so a lot of cerebellar involvement. He had some oculomotor dysfunction, which was poor gaze holding, poor target acquisition, aberrant optokinetic functions, and convergence insufficiency. So these are all prime indicators of how well his frontal lobes, his brainstem, and other visual integration centers were working, and generally speaking, they weren't working all that well. So his engagement with his environment through his visual system, his primary driver of learning, was not very good. Hyperanticipatory motor timing, speaking to his impulse control issues. Globally increased delta and theta brainwave activity. So in waking states, he's walking around with a tremendous amount of slow brainwave activity, leading to these feelings of kind of feeling stupid, brain fog, missing things. His brain simply cannot engage at a higher level. Poor olfactory identification, elevated blood glucose. So his gas in the tank was not very good. His brain was running on empty. This all led to increasing alcohol, tobacco, and technology usage. And this is a fellow who really didn't like to reach for things, but the fact is he felt so lousy, and some drinks started making him feel better. Some more drinks started making him feel even better than that. And now, it got to the point where it was just too much and actually starting to make him feel a lot worse. So he needed to do something about it. And he and his family, with the help of his family, helped get him in. He wants to quit again, but it makes him feel better. And I'm happy to say, after we talk about some of these things, he's really doing quite well. I want to put this in here. This is a American Academy of Neurology has recommendations for providers talking about anybody dealing with diseases of the brain need to understand that they produce changes in behavior and cognitive ability. So the bottom line is you have to measure these things. We measure all kinds of physical factors, balance and timing, and coordination of muscle strength and reflexes. We need to evaluate the end result of all that, the end result of our sensory and motor reality, our higher cognitive functions, because they will help us manage care long-term with these individuals, and also show them that they are in fact able to change their attention, their focus, their memory, all of these different things that they're struggling with. So that leads us right into this here. This is the individual, Jeff, 25-year-old male, underwent a battery of neurocognitive testing, about 40 minutes worth of testing. We looked at 16 cognitive domains of memory, attention, cognitive flexibility, executive function, psychomotor speed, all kinds of different things. A lot to look at here, but suffice it to say, there was profound improvement in a 5-day course of care with this individual, and I'll get to that in a moment. But fact is, the initial testing in November of 2017 revealed most of his cognitive domains. Now, these are compared to age-matched peers. So we're looking at other 25-year-old males without head injuries, without addiction, so on and so forth. The vast majority of his domains fell in the low average to very low categories. He had some in the average kind of bell curve area, and then some, just a small handful, couple in the above average category. When we retested on January 3rd, the vast majority of his values fell in the average and above average categories. So just one glance on this can tell us this is a brain that's working a heck of a lot better. When we look at key performance indicators of brain function relative to post-concussion syndrome and traumatic brain injury, those would be things like cognitive flexibility, executive function, that would be complex attention, simple attention. All of these areas, he had mid-teens and below relative to his peers. So he was in the 16th percentile with regard to cognitive flexibility on initial testing. He was in the 14th percentile with executive function on initial testing compared to his peers. His complex attention, 3rd percentile, simple attention, 1st percentile. Well, we saw profound gains, simple attention up to 40th percentile, 39% improvement right there. Also, 2, complex attention went from the 3rd percentile to the 30th, 27% improvement right there. And cognitive flexibility jumped to 66%, executive function to 81%. This is primarily through physical modalities coupled with cognitive and metabolic modalities. We're going to move forward here. So what we looked at with this individual was an intensive physical, cognitive, and metabolic rehabilitation program. Now, initial recommendations in concert with his mental health provider, who had actually referred him to us, was a 10 to 15-day program. He was dealing with some pretty severe issues that we just knew 5 days was not enough. This was all he had. He only had 5 days to commit to this because he needed to get back to work. So we just went in with the intention that we were going to do what we could in that period of time. So what happened was really nothing short of remarkable, as you see by the cognitive testing. There's other aspects of physical testing that we just simply don't have time to go over now, but he did have measurable improvements in balance, in eye movements, in motor timing, as well as quantitative EEG. So what happened was initially we looked at immediate intervention with database-directed neurofeedback for remediation of that slow wave activity. So his brain was bogged down with delta and theta brainwave activity, couldn't get into problem solving and tasking and planning and all of that. Worked out quite well for him. Metabolic protocols for blood sugar stabilization kept it very simple. got them off carbohydrates, got them on some good brain healthy fats. We didn't go into full-blown ketogenic diets, but we just did that, and his brain started to work a lot better. Self-regulation applications for emotional stability was critically important. He was very down on himself when he came in. So breathing, various types of tactical breathing and deep breathing exercises, hand warming biofeedback to initiate parasympathetic responses, whole body vibration, vagal stimulation with gargling and humming and bouncing on trampolines, and all kinds of things really helped him to start to gain control over his regulatory mechanisms and responses, both autonomic and psychological. We also looked at initial stabilization of aberrant eye movements, all kinds of eye movement exercises. He had significant challenges with posterior activation, with neck extension and activation of posterior semicircular canals. His balance would break down significantly. So we went ahead and started to rehabilitate that very aggressively, very quickly. And also his hyperanticipatory motor timing to control impulses more efficiently. We did that through the interactive metronome, and really he caught on to that very quickly and did quite well. So we had rapid progression to dual tasking activities where we took balance and cognitive tasks, put them together, and we'd also combine those into triple tasking now with motor timing tasks in conjunction with the balance and the cognitive. We also got into higher level self-regulation techniques with specific mindful meditation-based activities, which are much more frontal in nature and really help with this concept of self-regulation that we're going to discuss in just a moment. Then we did progression to home exercise protocol, and he did quite well with that. And again, happy to say he's doing quite well at this point. He's been having much less reliance on substances and certain behaviors due to the fact that his brain is simply more engaged with his environment through his sensory systems. So self-regulation, what I was just speaking about with this particular fellow, this is really important to understand. The ability to monitor and control our own behavior, emotions, or thoughts, altering them in accordance with the demands of the situation. That is self-regulation. So we need to inhibit first responses, resist interference from irrelevant stimulation, and persist on relevant tasks even when we don't enjoy them. This was written by Joan Littlefield Cook, who is a behavior specialist, and this is self-regulation. This is our ability to exercise our dorsolateral prefrontal cortex and other aspects of frontal and prefrontal function that govern our higher cognitive abilities that can help us get past not only addiction, but pain associated with addiction, and also the ramifications of mild traumatic brain injury and post-concussion syndrome. Self-regulation is a critical tool that needs to be employed with any process of physical rehabilitation and metabolic rehabilitation. And really, in some cases, the only way to access the higher level mechanisms that will shut down the subcortical circuits that are going on and on and on that continue pain and addiction without our ability to stop it as a human function. So I put some resources here. I know this is kind of a fast and furious approach. I really hope you enjoyed the connection between these topics here and the understanding that they are in fact connected. I encourage you to read as much as you can in this area. There's more and more coming out every day. I post a lot of it on a closed Facebook group called Brain-Based Addiction Recovery. I have a podcast that I do as well, webinars and workshops that come out all the time talking about these things. There's an addiction recovery ebook that you can get through this virtual summit right here. So look at the bio there and you can pull that up. And I encourage you too to email me. Request no solicitations, please, but please email me if you have questions, if you want resources. I'm more than happy to help you. This is my passion. This is what I do. And I just love sharing that. So it's been an absolute pleasure to be a part of this virtual neurology summit and to spend this half hour with you. And I really hope you enjoy the rest of the presenters and have a great time.